Just a heads up. Okay, we've hit record. Perfect. All right. Just as reminders, as folks are trickling in, I'd like to remind you to keep your cameras on if you can, and your microphones off with the exception of the presenters. We'll have 3 presentations for today's session here, and so I'll be keeping time and letting folks know when they're getting close to their allotted time. We've got about 15 minutes and some time for Q&A at the end. And so we've got 3 speakers lined up. But first up, we have Patty Wilson, who will be talking to us about barriers and facilitators to the uptake of prescribed safe supply at Kaa-Wiichihitoyaahk Family Services. Don't quite see Patty on the call just yet.
Oh, sorry, I am here. I wasn't sure if that was my cue to go or not.
Perfect. Yes, Patty, there you go. Yes, feel free to share your deck here and get started.
Sure. Oh, right. And just making sure that everyone can see, it should be just the title slide, no speaker's notes, if that's correct.
That's correct. We can see that.
Okay, perfect. All right. So I'll get started. Hello, everyone. My name is Patty Wilson. I am a family nurse practitioner, and this research I'm presenting today is part of my Doctor of Nursing program through the University of Toronto, which is called Barriers and Facilitators to the Uptake of Prescribed Safer Supply at Kaa-Wiichihitoyaahk Family Services. This research was funded in part by the Bertha Rosenstadt Health Research Fund, which helped cover the cost of honorariums for participants. I'd like to start by introducing myself. So I am of mixed European ancestry, German, English, and Irish, and I want to acknowledge that I am an uninvited guest on the land that I live, and I also want to describe my commitment to reconciliation. So where I'm calling in from today is Treaty 7 territory, which includes the Blackfoot Confederacy, comprised of Siksika, Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, which includes Chiniki, Bearspaw, and Goodstoney First Nations. I also want to recognize the Otipemisiwak Métis government of the Métis Nation within Alberta. And I want to acknowledge that the topic I'm speaking on, which is prescribed safer supply in the toxic drug crisis, there may be people listening today that are directly impacted by this crisis, and just to take care during my presentation of some of the findings. So while I'm calling in from Treaty 7 territory, this research took place on the traditional territories of the Kaa-Wiichihitoyaahk people. And including a land acknowledgement isn't just a formality for me, it's about grounding this work in place and in relationship. As a non-Indigenous researcher, I see this as part of my responsibility to engage with the Truth and Reconciliation Commission's calls to action, especially when working with a First Nations governed health organization, which Kaa-Wiichihitoyaahk Family Services is. It's a First Nation governed health system that serves 11 member nations in northern BC, many of them rural and remote. These communities are severely affected by the toxic drug crisis, which has prompted Kaa-Wiichihitoyaahk Family Services leadership to explore safer supply implementation. Northern BC has some of the highest rates of toxic drug deaths in the province and some of the lowest numbers of safer supply prescribers. This highlights a serious health equity concern. The rate of fatal poisonings in the northern region of the province, which is where Kaa-Wiichihitoyaahk Family Services is located, is over 4 times higher among First Nation people compared to non-First Nation populations. First Nation peoples make up just under 15% of the population in the north, but represent 43.6% of deaths from toxic drugs. This reflects the impact of colonial violence, dispossession of land, anti-Indigenous racism, discrimination, and multi-generational, intergenerational trauma. Importantly, these are not just numbers, these are people who have families and friends that miss them. At the heart of this research is a commitment to the TRC call to action number 19, which urges governments and health systems to close the gaps between Indigenous and non-Indigenous populations. And so by exploring the barriers and facilitators to prescribing safer supply in this unique setting, I'm aiming to contribute to efforts that close these gaps and support equity and care in line with TRC call to action number 19. So first, a bit about what is safer supply. The goal of safer supply is to provide prescribed alternatives to a toxic drug supply for those who are at risk of overdose and death. For this project, I focus on opioids only. So as an example, that would be prescribing hydromorphone tablets to someone to reduce their use of illicit fentanyl, thereby reducing the risk of overdose and death. Early research has shown that safer supply reduces opioid-related mortality, as well as all-cause mortality for those who are able to access it. Despite this early research, uptake among prescribers has been low and is in fact declining. From the literature on safer supply in Canada, we can see some existing barriers and facilitators. Some barriers include things like limited resources, like lack of staffing, lack of funding, a lack of social acceptance of safer supply, rigid regulations, that includes things like overly prescriptive guidance documents, or a lack of support from regulatory colleges. On the flip side, some of the facilitators include a higher uptake of safer supply prescribing in primary care compared to other healthcare settings, using a harm reduction lens in prescribing, and having supportive colleagues or strong team dynamics. A key gap in the literature is the northern, rural, and remote context. Most of the studies that exist focus on large urban centers like Vancouver, Toronto, or London, Ontario. Even when northern and rural remote perspectives are included, prescriber perspectives are often lumped in with urban data or blended with patient perspectives, which makes it really hard to really understand what's happening in rural practice among clinicians on its own. And so for my study, I used a qualitative descriptive approach. I did 8 virtual semi-structured interviews between July and December 2024. Participants included Carrier Sekani Family Services staff, which included prescribers, so physicians and nurse practitioners, as well as members of their substance use and addiction services team. This is a specialty team that's involved in the delivery of safer supply and includes health disciplines like pharmacy and nursing. The interview questions were developed using a framework, which is the COM-B framework. This is an implementation science framework. Implementation science, it's an area of research that focuses on the study between the research to practice gap that exists. And because I wanted to understand what is that gap, what are some of the challenges that contribute to that gap at Carrier Sekani Family Services, and what are the strengths within that organization that already exist to help close that gap. I used Braun and Clark's thematic analysis, and I drew on the COM-B framework to help organize my findings. And when I planned the study, I centered it on the 4 R's of Indigenous research described by Kirkness and Barnhart, which includes respect, relevance, reciprocity, and responsibility, and on Ermine's concept of ethical space, which keeps distinct worldviews and honest dialogue. Using an Indigenous-founded research framework to shape the way I engaged with Carrier Sekani Family Services allowed me to respond to a community-identified need, maintained accountability of my relationship with Carrier Sekani Family Services, and helped avoid research that was extractive. So the findings. So the first theme focuses on health system, geographical, and social impacts of safer supply uptake that are unique to the setting of Carrier Sekani Family Services in Northern BC. There are a few sub-themes underneath this first theme. The first one is what I've called structural constraints in care. This highlights some of the bigger system-level barriers that made it hard for our participants to prescribe safer supply in practice. People on this call will probably be familiar with many of these. First, there was limited access to healthcare in many of the communities. That included not just prescribers, but things like pharmacy access. Second, safer supply guidance documents that were published and designed to serve as guide for clinicians to implement safer supply in their practice included expectations like daily dispensing of medication, which in the context of a rural and remote setting with few health resources presented a real barrier. As this participant describes, quote, The distance to the pharmacy, the lack of transportation, inclement weather make daily dispense almost nearly impossible. The next subtheme highlights the social barriers that shaped how participants experience prescribing safer supply. One of the biggest challenges was a dominant abstinence-based narrative in some communities and among some healthcare leads. Under an abstinence-based approach to substance use, safer supply was often seen as opposite of recovery or treatment, and therefore harmful or enabling. This was compounded by the influence of media and political discourse, where misinformation about safer supply was common. In those narratives, those political and media narratives, safer supply was often falsely linked to crime, growth of encampments, and community social decline. And some important context for carrier Sekani Family Services communities is that participants were often providing care to the entire community. And they described needing to think carefully about providing safer supply because of that wider narrative that vilified safer supply, because it could harm their relationship with the entire community. As this participant describes, quote, "I think it's more like worry that people in the community would feel like I was contributing to the drug problem in terms of like maintaining a therapeutic relationship because we see the whole population." The next theme, complexities in decision-making, explores important facilitators participants experience when making clinical decisions in safer supply prescribing. Responsive decision-making describes participants' ability to adapt their decision-making based on patient needs and really highlights the cognitive skill and psychological stamina that was required to navigate safer supply care in this unique setting. An example of this is described by participant 7 here. Quote, "You try and figure out what the best thing is for them, like what you can offer to help them. And that might be a fentanyl patch, or it might be something else, or it might be nothing you can offer." This decision-making capacity was further strengthened by collaboration with other healthcare partners. This helped support creative problem solving when faced with barriers to safer supply care that was unique to the northern rural and remote setting. The next theme is moral dilemmas in care. There were two main sources that participants described with moral dilemmas in care that acted as a barrier to prescribing safer supply. The first came from trying to prescribe safer supply in a context where the guidelines were not built for their setting. A lot of protocols didn't account for the realities of northern and rural practice. When providers needed to adapt or deviate from those guidelines and meet patient needs, they worried about possible repercussions from their regulatory colleges. The second source of moral distress was the broader context, working on the front lines of a toxic drug crisis. Participants were seeing community members die at devastating rates, and they were trying to deliver care in the middle of that loss and that urgency. As this participant describes, quote, "I was in rural community number 2, and they had canceled having kids make things for Mother's Day at school because so many kids had lost their moms that year." Switching to facilitators, the final theme is transformative encounters. This theme captures the deep emotional impact participants felt when they saw safer supply make a real difference in patients' lives. Many describe moments where access to safer supply led to meaningful change, including improved patient autonomy, increased access to healthcare, or access to First Nation end-of-life ceremony, which we can see in this first quote. Quote, "Because of safe supply, she was able to participate in 2 of her brother's ceremonial end-of-life activities, and she just had so much healing for her to be able to participate in his end-of-life ceremony and protocols." Participants' commitment to this work wasn't just clinical, it was personal. It was grounded in their values, both as professionals and as people, which we can see with the second quote from participant 8, quote, "I think that, yeah, like building those relationships and like on an individual level, one patient at a time or one family at a time, is how I can, as an individual, contribute to reconciliation." Since my data collection has wrapped up, there's been a significant safer supply policy change in BC. Now, all safer supply medication must be consumed under supervision, either at a pharmacy or a health center. So prior to this change, patients could go to a pharmacy, health center, pick up their day's worth of safer supply medication and take it as they need it throughout the day. Now, every single dose must be observed in a health center or a pharmacy. For safer supply for Care Sekani communities, this likely means an end to their safer supply program. And perhaps you're thinking, is my research findings even relevant in the context of this change? I would argue they are for a couple reasons. First, The structural limitations that participants described, such as limited pharmacy access, rural geography, is the exact reason why the change to witness dosing is unworkable. The findings highlight how a one-size-fits-all safer supply model is unfeasible. This could inform future policy decisions, such as community-based witnessing or exemptions for rural and remote care. And as well, this research is part of answering the TRC call to action number 19 to identify strategies to close health gaps between Indigenous and non-Indigenous populations. That relevance doesn't disappear with this policy change, it becomes more urgent. So what does this all mean for Northern BC? My research points to three key takeaways. First, we must recognize that current safer supply models are not realistic for Northern realities. The current rigid guidelines often create more barriers than they solve. We need policies that support flexibility, recognizing that what works in dense urban centers is not practical in Northern BC. Second, we need to advocate for and develop rural-specific protocols. Providers need guidance that acknowledges their context and empowers them to make safe, effective decisions. This could reduce prescriber hesitancy and improve consistency of care across the North. Crucially, these protocols must be developed in the communities in which they will be implemented. And finally, collaboration is absolutely critical. This study shows that motivated and skilled workforce is being held back by a system that isn't fully supportive. Building stronger, more intentional partnerships between frontline teams, regional health authorities, and community leaders is essential for creating an environment where these life-saving interventions can succeed. And if people are feeling generous, I would very much appreciate feedback. Perhaps if it's okay, I'll just leave them up on the screen for about 15 seconds so people can grab it if they need to.
Absolutely. Thank you so much, Patty, for that
Yeah,
fantastic presentation.
Yeah, thank you. I will leave it there then.
Right. Yeah, I'd like to invite the audience, if we've got questions from the group, now is your opportunity to ask. We've got 5 minutes for Q&A. So if you've got questions, please just either post them in the chat or raise your hand and I can unmute you and we can do it that way. Oh, Donna's asking for the QR code. Are we able to share that, Patty?
Definitely. I just need to get things set up here
Sure.
again.
All good?
Okay, I think you should be able to see it again there.
Yes, we can.
If people do not want to provide, if people do not want to ask their questions here, is it all right if I put my email in the chat box? Okay.
Absolutely. Yeah.
All right. Oh, I think I
Perfect.
put that
I
in the
think you
wrong
just
chat
sent
box.
it to
Sorry.
me. Yeah.
Sorry
all
about
good.
that. Let me do it one more time.
Sure. So now's your chance. If you've got questions for Patty, please feel free to. It's a safe space. Feel free to speak up and ask. If not, Patty, I think my question to you, I know with these presentations and structured timelines, things are always very constricted in terms of what you can share. Is there anything that you felt you would like to have shared and didn't perhaps have the time for it within your presentation?
Yeah, thank you for that. The one thing, I mentioned it a little bit, but I really would like to emphasize what I think is really unique about Northern BC, and just within that interesting sort of unique environment is the amount of emphasis there is on relationships in order to help patients access care. So a lot of participants described, relationships they had formed with pharmacy or strong relationships they had formed within team members. And even when they were brainstorming what could they do as an organization to help increase the uptake of safer supply, a lot of it was relationship-based strategies. So a lot of them talked about connecting with colleagues who do not currently prescribe safer supply or connecting with leadership. And I just don't think that's something that you hear in larger, denser urban environments. And I think that's something that is a real strength and deserves one, like incredible recognition that it is a relationship-based approach to care and problem solving. And two, and this is me as a researcher speaking, I think it deserves more focus as well in research and how that is very unique to the North as well.
Incredible. No, thank you for sharing that. I think many of us in the North would we really appreciate that sentiment. Often we look at the North, and so it's from a deficit perspective when we're looking at research and exploring, in resource limited environments and not having enough providers and some of the challenges. And so absolutely, I think most folks in the room can agree with the fact that relationality and relationship building is, key strength of our communities. And we see that in our work day in and day out, as many of us wear multiple hats. So thank you for that.
Yeah, I think I'll stop sharing now.
Sure.
I think probably that's been enough time, but
Perfect.
okay.
Thank you. We've got a minute if anyone's got any last questions that have come up. If not, Patty has kindly provided her email as well as a QR code to share some of that feedback. Amazing. Thank you so much, Patty, and great job. Perfect. So I guess we'll head on into our next presentation, continuing on with the theme of promoting Indigenous health equity. We've got our next two presenters. We've got Alexanne and Eva Habib, and they will be presenting on Kaa-Wiichihitoyaahk. We take care of each other. Ali was kind enough to share the pronunciation with me, so I hope I got that right. And Ellie, if you could share your screen, please.
Awesome, thanks, Damon.
Slides
Eva will be sharing screen today. I think a lot of folks in the North can resonate with some power problems, and I just lost power at home, so we're gonna shuffle. But thanks.
Perfect.
Those up.
Yeah, and we can see that.
Awesome. Okay, hello and welcome, Tansei. Thank you, Marcy, for joining us this afternoon. We're grateful to be here with you to share some of the important work happening in partnership with Northern Health and Métis Nation BC. Today, we'll be speaking briefly about the Métis, their distinct identity, their experiences within the healthcare system, and how we can work together to improve health and wellness outcomes in culturally respectful ways. So on this slide, and as Damon just said, you'll see the phrase Kaa-Wiichihitoyaahk, which means we take care of each other in Michif, the Métis language. We chose this as the title of our presentation because it reflects a core value in Métis culture, caring for family and community. So for those of us working in healthcare, embracing Kaa-Wiichihitoyaahk means practicing cultural humility, showing kindness, and honoring the traditions and strengths of the communities we serve. It's about creating space for Indigenous ways of knowing and being, and recognizing that wellness includes connection, respect, and belonging. I'd also like to acknowledge the beautiful digital artwork featured in these slides, which is created by Métis artist Nevada Christensen. Her work brings visual life to the stories and values we're sharing today. So my name is Ali Dick. I use she, her pronouns, and I'm grateful to be joining you all today from the traditional, unceded, and ancestral lands of the Wet'suwet'en Nation in the Smithers area, which happens to be a very stormy area today. This area is also the chosen home of the Tri-River Métis Association, which is one of the 11 Métis chartered communities serviced by Northern Health. My family roots are Quebecois, English, and Scottish, and I work as the Métis Engagement Liaison with the Indigenous Health Team at Northern Health. And in this role, I have the privilege of working closely alongside Métis Nation BC. I'm excited to be presenting alongside my colleague and friend Eva, who I will invite to introduce herself.
Thanks, Ali. Tanshe Kiawao. Hello, everyone. My name is Eva Habib. I use she, her pronouns. I'm a second-generation settler of refugee parents with proud ancestral roots from Kabul, Afghanistan. And it's with great respect and gratitude that I'm privileged to be joining you today from Kaa-Wiichihitoyaahk First Nation lands on unceded ancestral shared territories of the Coast Salish peoples in the lower mainland of BC and what's also known as New Westminster, and the chosen home of the North Fraser Métis Association. I am the Senior Manager of Métis Health Equity with the Ministry of Health and Wellness at Métis Nation, British Columbia. Thanks so much for your invitation for having us today and allowing us to present. It's an honor to be sharing with you all about our work and to be doing it alongside Ali.
Awesome. So before we begin, I'd like to acknowledge the traditional territories of the First Nations across the region that we work within and support. We honor and give thanks to them as the inherent and traditional stewards of these lands, waters, and skies since time immemorial. And I invite you all to take a moment to reflect on the land in which you are joining from today. And I'd also like to take a moment to acknowledge the many partners that work alongside us, including the 11 Métis chartered communities across the North, who each have dedicated leaders and teams supporting Métis citizens and community members.
For some of you, the term Métis Chartered Community might be unfamiliar. These are volunteer-run associations that exist to help Métis citizens and self-identified Métis individuals connect with each other and with their culture. As the heart of the nation, each chartered community plays a vital role in supporting its members. They offer cultural programming, organize social events, and help Métis access funding opportunities and resources. While they don't provide health services directly, they are powerful advocates for the needs and priorities of their communities. When we use the word community here, we're talking about a social structure, a network of relationships, shared values, and collective care. Métis chartered communities often host cultural gatherings, seasonal celebrations, and advocacy events and initiatives that strengthen identity and belonging. It's also worth noting that these communities operate with very, very limited resources. They're entirely volunteer run, often with minimal staff and office hours. But despite these constraints, their impact is significant. Today, there are 39 Métis chartered communities across BC, with 11 located in the northern region alone. As of this year, there are approximately 5,500 registered Métis citizens living in the north, a vibrant and growing population. Who are the Métis? This is a question that is a very big and beautiful answer to it, and with the interest of time, I'll try to keep it brief, but want to acknowledge that there is so much cultural and historical richness to the Métis that we just won't be able to get into today, but Ali and I encourage you to learn more about. The history of the Métis Nation began in the 1600s and 1700s when French, Scottish, and English fur traders intermarried with First Nations women, many of whom were Cree or Saulteaux. This resulted in a generation of mixed descent children who often intermarried with others of mixed descent, continuing the process over many generations. Métis families collaborated to establish their own communities and settlements, creating and maintaining distinct cultural norms. The Métis are recognized by Section 35 of the Canadian Constitution Act of 1982 as one of 3 distinct Indigenous peoples in Canada. Métis Nation British Columbia is the Métis provincial government in BC, supporting over 30,000 registered citizens and advocating for over 113,000 self-identified Métis across the province. Métis view health and wellness holistically. At the heart of Métis well-being is cultural wellness, the ability to live authentically, express culture freely, and feel safe from discrimination. Creating spaces, Is that jumping ahead? No. Okay. Creating spaces where Métis can be themselves is essential to health and healing. Most of you are familiar with the term cultural safety, and in this context, Métis are striving for cultural wellness. To understand the barriers Métis face in healthcare, we need to consider both historic and current experiences. Colonial policies and systemic exclusion created lasting impacts, including intergenerational trauma. Many Métis once hid their identity to stay safe or be accepted in society. However, Métis resilience is remarkable. The continued strength of Métis culture speaks to that. Today, many are reclaiming identity and healing through culture and community. When we foster spaces where Métis feel safe, seen, and valued, we support collective healing and a stronger Métis nation.
Awesome. So we will now move into sharing about the partnership and collaborative work underway between MNBC and Northern Health. So in 2020, a letter of understanding, or LOU, was signed by both partners, formalizing a shared commitment to improve access to care and promote equity for Métis across the region. The LOU laid the foundation for working together to enhance Métis health and wellness outcomes and to ensure Métis voices are included in decisions that affect their healthcare experiences. So recognizing the need for a clear and actionable roadmap, we co-developed a 5-year Métis Health and Wellness Plan in 2023. This plan outlines key priorities, goals, and timelines to bring the commitments from the LOU to life. The photo you see here was taken at a Métis Health event hosted by MNBC in the fall of 2023. It was the first gathering of its kind with about 70 Northern Health leaders and staff in attendance. It was a powerful day of connection, learning, and relationship building, and a meaningful step forward in this partnership. And here's the cover page for the MNBC Northern Health Métis Health and Wellness Plan. So guided by the principles of culturally safe and equitable care, the plan identifies key areas for change, outlines joint actions, and sets out a vision for transformative outcomes over the next 5 years. This work reflects how we're collaborating to strengthen care delivery, ensuring that services provided to Métis are free from racism and discrimination, and that they are culturally safe and accessible. I'm excited to share that the public version of this plan was released in January of this year and is now available through MNBC's website, as well as Northern Health's Indigenous Health website. And I believe there's also a few physical copies in the Northern Health library as well.
The Métis Health and Wellness Plan is grounded in several key resources and documents, some of which you're probably familiar with. One of these is the In Plain Sight report, which highlights Indigenous specific racism in BC's healthcare system. Another is Kaa-Wiichihitoyaahk, a book that shares Métis perspectives on cultural wellness, which the title of this presentation is inspired by. And finally, Tanchikia, a public health report published in 2021 in collaboration with the Office of the Provincial Health Officer, which sets out recommendations, goals, and benchmarks to guide progress in Métis health and wellness. If you're looking to better understand the current health landscape for Métis in BC, we really recommend reading this report. This is a snapshot into what are some of the key areas of the priorities that are in the Health and Wellness Plan. We have a total of 4 priority baskets of work, including Métis cultural wellness and anti-Indigenous racism education and training, patient experience and health concerns, human resources and recruitment and retention, and finally, health services grounded in Métis cultural wellness, which covers topics such as access, data collection, quality service delivery, and cultural mental health and harm reduction supports. We have identified teams and leads from both organizations to move these priority baskets of work forward and act on our shared commitments. This work is novel in many ways and will be critical to improving access and equity to care for Métis.
So the Health and Wellness Plan was established through meaningful community engagement. In the summer and fall of 2023, we hosted sessions with Métis leadership and community members to validate priorities and gather feedback, ensuring the plan reflected community voices and direction. Métis charter communities also shared their own health and wellness priorities, placing Métis perspectives at the heart of the process and ensuring that we were moving in the right direction. So as implementation continues, we remain committed to ongoing dialogue and creating future opportunities for Métis citizens to guide our progress. The photos here show some of our in-person engagement sessions, and shout out to Donna, who I see is in the room here with us. So these sessions included presentations, sharing circles, and interactive poster activities where participants marked goals with heart-shaped sticky notes that resonated most with them, and many added written comments to highlight gaps or new ideas. We also hosted a virtual feedback session and online survey to support broader participation across the North. And using Mentimeter, we gathered real-time input reflected in the word cloud in the bottom left here. So we're proud to share that several initiatives from the plan have already been completed, with many more currently underway or on the horizon. One major milestone is the development of a Métis-specific cultural safety training curriculum titled Mi'o-Pimatisawen, Métis Cultural Wellness Education for Healthcare Professionals. This course has been officially approved, just freshly approved by UBC Continuing Professional Development for credit, and its first offering will take place in a short couple weeks in November. We're also celebrating the unveiling of framed Métis sash art pieces at Northern Health facilities across the North. These beautiful works are now featured in locations including the Bulkley Valley District Hospital, the Kitimat Regional Hospital, Prince Rupert Health Unit, and the Prince George Virtual Clinic. Encouraging Métis participation in health careers has also seen some meaningful progress. So in February of 2024, there were 340 Northern Health employees that self-identified as Métis. And by March of 2025, that number had grown to 375. And looking ahead, there's several initiatives that are in motion. So some mental health and harm reduction teams are working together to develop a shared referral pathway to improve access to mental health and substance use services for Métis citizens. We're also in the process of re-signing the Letter of Understanding between MNBC, Northern Health, and the 11 Métis Charter communities in the North. And this time, the process for signing the LOU will be community-driven, something that was missing in previous iterations. And finally, work is underway to improve physician Métis patient attachment rates. And this effort aims to support consistent, culturally safe care throughout a Métis person's life journey. So to track and monitor progress on the plan, we've established shared accountability frameworks that measure outcomes over time and ensure transparency. Regular meetings with project leads help review deliverables, assess our progress, and share updates with one another. All data is compiled in a centralized Excel-based system supporting regional tracking, biannual summaries, and reporting, which are all tools that promote evidence and values-informed decision-making. Our leadership committee, which you see in the photo here, which includes MNBC's Minister of Health, Northern Health CEO and President, and MNBC's regional directors, meets twice a year to advance LOU commitments and plan priorities. We also hold themed technical working group meetings quarterly that bring together MNBC's Ministry of Health and Northern Health's Indigenous health staff. These action-oriented sessions focus on collaboration, decision-making, and driving measurable improvements in health outcomes for Métis citizens.
So finally, we have a couple of calls of action for you all. We invite you to continue learning more about this important work and explore ways to get involved. The Health and Wellness Plan, as mentioned, is available online through both the MNBC website as well as Northern Health's Indigenous Health webpage. We also encourage you all to keep an eye out for our upcoming offerings of Mio Pimatisawan, Métis Cultural Wellness Education for Healthcare Professionals. There's also a wealth of information and resources available on the Northern Health Métis webpage, including updates, tools, and stories that reflect the ongoing work in all of our communities. And finally, we invite you to connect directly with Ali, the Northern Health Métis Engagement Liaison. She can help you learn more about the initiatives underway between MNBC and Northern Health and how you and your team can contribute to this meaningful work. There's also a QR code on the screen there for people to access. And finally, here is our contact information should you need it. And that brings our presentation to an end. Kitchen Marcy, thanks for having us, and we'd be happy to take any questions.
Fantastic. Thank you so much, Ali and Eva. Inviting questions from the audience now. If folks have questions, feel free to pop them in the chat or unmute yourself. It's a fantastic presentation and some mention of resources that were new to me. So thank you for that. Donna, I see you're off mute. Did you have a question?
Yeah, I was trying to look for a little hand or something.
Oh, sure. Go ahead.
Okay, I was just wondering, you were saying that the first education session for the new curriculum is going to be happening in the next couple of weeks. Whereabouts is that going to be taking place?
Yeah, thanks, Donna. So the first offering is happening in the Lower Mainland. This curriculum is an offering that's going to be province-wide. So similar to that photo you saw where everyone was sitting in a round a sharing circle, it's going to be an event like that, but with that Fraser Health focus as the folks invited. So it's happening in the Lower Mainland. But that being said, with the rollout officially kind of happening, we're going to be reaching out to teams who've expressed interest in taking the training. There's already a lot of folks at Northern Health who've put their hand up to hear about when the offering is available. So we will be starting to reach out and offer it in the North.
Thank you.
Amazing, thanks. If there are other questions, feel free to unmute yourself or pop them in the chat. And while folks are getting their questions together, I think as you, Ali and Eva, as you were speaking about some of the different work that's happened, I was particularly drawn to the recruitment and retention of health professionals, and wondering if perhaps you could share an example or two of some initiatives that of work that have gone into helping boost that.
Yeah, absolutely. So we are so fortunate to have a really incredible Indigenous recruitment and retention lead at Northern Health, Melissa Moran, who has been living into the actions and goals of the health and wellness plan, like full steam ahead. So we've been meeting regularly with MNBC's Ministry of Skills Training, Employment, and Post-Secondary to just explore ways that we can work with one another, find sources for funding to support Métis folks with developing careers in the healthcare world. MNBC has invited our team to attend career health fairs or like career fairs, and Melissa's also been busy developing Métis specific marketing materials to promote health opportunities to Métis folks, to invite them to work at Northern Health. Those are just a few coming top of mind, but there's been a lot of different actions. Yeah, it's been great to just have both teams work together brainstorming, and yeah, those numbers are, I think, reflecting that. So another one is also just encouraging self-identification within our staff, and just kind of making clear the messaging of like why that's important. And actually one more thing we're going to be rolling out shortly is giving Métis flag pins to Métis identifying staff, just to bring visibility to our staff that work, and also to create safe spaces for Métis patients and families that come into our facilities. So lots of different work happening.
That's fantastic. Thank you so much for sharing. That's a number of different projects, and as you said, it's reflected in the rates of self-identification that you're seeing, and so it's always great to see that in action. All right. Do we have any other questions from the audience? I don't want to be the moderator that takes over the Q&A period. So if we've got questions or comments, or got about a minute left.
Maybe I'll just add, if there's no other questions, the interesting piece around kind of the recruitment and retention piece is really being able to create not just like psychologically safe workplace environments for people to feel safe to self-identify as Métis. We've been hosting some in-person events over the last couple of years, and have invited many health authority staff into those events, and repeatedly have found that it's the first time that people have openly identified themselves to their colleagues as being Métis, because they're finally entering a space where they feel safe to do so. And so that's been something that's been really powerful about some of the initiatives that we've had. And as Ali mentioned, with the pins that we're hoping to distribute when staff do self-identify, again, it's really meant to be two ways. It's meant to be providing a space in a workplace for people to proudly identify as Métis, but also to invite patients or clients who might be coming forward as Métis to see a symbol that they recognize, and then they themselves can feel like they can enter a more culturally safe encounter with someone. So that's the hope with that moving forward too.
Amazing. Thank you so much for sharing that, Eva. Fantastic presentation.
Thanks
so in
for
the
having
interest
us.
of course, in the interest of time, we'll be moving on to our next presentation and our final presentation for this series. We've got Jennifer Cochran here to present on opportunities to enhance Indigenous data sovereignty, lessons from the introduction of molecular diagnostics in First Nation communities during the COVID-19 pandemic. And so, Jennifer, I will invite you to share your slide deck.
Okay. Can you see it there?
Not quite. No, not yet. Yeah, it looks like it's loading. So.
Still?
Perfect. We're good to go. Take it away.
Awesome. Miigwech for the introduction. Hello, everybody, and Miigwech, thank you for joining me. My name is Jennifer Cochran, and I'm Mississauga Anishinaabe, and I'm a citizen of Curve Lake First Nation. There's some pictures here. Is my Nokomis on the bottom left, and there's my family in the middle. There's my daughter and son in the background, and there's my daughter holding lakeweed and is definitely about to throw it at me, which she did. I'm presenting today from Wet'suwet'en territory, just like Ali. Ali, we should grab coffee sometime, where I'm privileged to serve First Nation health interests in my role as a manager of clinical informatics systems with FNHA. So today I'll be presenting my thesis as a part of my Master of Health Sciences program at UNBC. This work was guided heavily by my supervisor, Dr. Margot Parks, and my committee members, Dr. Daniel Bain-Smith, Dr. Courtney DeFriend, and Dr. Tammy Clausen-Ross. So my research explores how implementing community-based molecular diagnostics during COVID-19 impacted Indigenous data sovereignty and nation-based decision-making in First Nation communities. So here's just a quick overview of what I'm going to cover today. Just want to note that my thesis is still on embargo. We're just exploring publications opportunities. And yeah, so the project that I want to talk about first, Bringing Testing Closer to Home initiative. It is really the seed of this research concept, and it emerged from during the pandemic. There was an urgent need for accessible health services, specifically diagnostic services to test for COVID-19. And within my professional role at FNHA as the clinical lead, it was part of my role to deploy these instruments, these gene expert instruments, which is the picture on the left there, which is essentially like a lab in the box. And my role was to just help roll these out so that testing could happen in a high quality way in remote communities, some places only accessible by plane or by winter. So this experience shaped my curiosity about how diagnostics and all the data that they generate can not just support health service access and outcomes, but actually self-determination and data governance and environmental stewardship. So this is kind of where my special interest in diagnostics and technology all bloomed from. And the research that I focused on is really deeply personal. It's grounded in my teachings that connect land and water and climate and health, and challenges the idea that innovation must always be something new. Sometimes innovation means returning to relationships, to the way that we used to do things, to our teachings, to Aki, Mother Earth, and our responsibilities as Indigenous researchers and leaders to honor Indigenous ways of knowing that colonial systems have tried to sever. So this study focused on community-based diagnostics in rural and remote First Nation communities during COVID-19 and covered principles in Indigenous data sovereignty and self-determination. And the overarching guiding question that I had was, what can be learned from the implementing of community-based molecular diagnostics during COVID-19 to inform collective understandings of Indigenous data sovereignty and nation-based decision-making in public and environmental health? So my objectives, they were to examine how diagnostics were implemented in rural, remote, and First Nation contexts during COVID, and then also explore their potential for place-based data collection and health governance, specifically in the realms of public and environmental health. So within my thesis and with this presentation, language really matters to me. I use these terms in a relational and intentional and purposeful way. Mostly to honor specificity and collective struggles and Indigenous ways of knowing and being. So I use Indigenous when I'm speaking to like shared teachings, shared struggles, and systemic issues that we've all experienced as Indigenous people, like colonialism and data disposition and policy reform. And I use First Nations when I'm referring to the communities in this study, as the research was done specifically in relation to First Nation. I didn't have opportunities to expand into Métis, Inuit, or other nations, mostly because of my work within First Nations Health Authority. And I used Turtle Island to reflect the borders in the Americas to center land-based understandings rather than colonial maps and really rigid defined borders that were imposed without our full consent. So the research was never just about diagnostics or people health or access to services. As a Anishinaabe, to me, it was also about how I could tie in land as well, because for us, our teachings tell us that health of ourselves and our communities is inseparable from the health of our Aki, so our earth, our water, our air, and all of our human and non-human relations. These teachings form the foundations of systems thinking, and they got us to make decisions for the collective, our ancestors, communities, and future generations in mind. So throughout this work, I sought to practice what I kind of like to identify as Indigenous scientific method, which is essentially everything that exists in Western science method, process-wise, but adding also heart, spirit, and interconnection with all of our relations into the mix. So the literature review showed that Indigenous data sovereignty affirms the right of Indigenous peoples to govern their own data, decisions, and health systems. So you may be familiar with frameworks like OCAP and UNDRIP and DRIPA to support these rights, but implementation and practice really lags within the health realm. So my research responds to these gaps, calling for place-based Indigenous-led approaches to data and diagnostics and health governance that is really just concrete and actionable from an operations perspective. This research was guided by my 7 grandfather teachings and by Kwakwen, Kobaid, OCAP, and the critical place theory. It would take me a really long time to pay respect to these types of teachings, so I'm not really going to go deeply in them today, but I did kind of want to highlight the teaching of Kobaid, which is beautiful to me. It means a link in the chain between ancestors and future generations. And in the language, it translates into the feeling as your grandmother's grandmother are embracing your grandchildren's grandchildren. So throughout this research, the intention was to honor those that came before and many of those who lacked access to diagnostics or health services and died from it. And then hopefully the future of our grandchildren who maybe won't have to go through the same inequities. So I had 8 participants. They were recruited through relational methods, similar to snowball sampling, as it's defined in Western literature. So I knew some folks like from working within FNHA in the diagnostic realm. So I reached out and asked them if they'd be interested, and also asked them if they knew anybody else that would be interested. The group represented community health staff and leaders working in First Nation communities, provincial and national diagnostics experts working in the overall project of bringing testing closer to home across Turtle Island, and participants were chosen for their current and active role in diagnostics implementation and also experience with doing that work during COVID. It wasn't distinctive to any individual First Nation community, and I didn't have indigeneity as a inclusion criteria, mostly because that was really hard. There was challenges for me from a research ethics perspective with time. I was currently working full time. I'm a mom of 2. So I didn't deep dive into that inclusion criteria as much as I would have liked to if I had more time to do so. But I did keep it still relevant to, I think, the findings, in my opinion. So I aligned the work with this and the coding with the 7 grandfather teachings, and I really tried to practice honesty and humility by rechecking my transcripts, reflecting on bias, and grounding analysis in the participants' truths that they shared with me. So now I'm going to just walk you through the key findings from participant insights and thematic analysis. Those is what I use, thematic analysis. So the key themes identified are as shown here. So finding number 1, was relationship and capacity. So technology alone isn't enough. Education, trust, and relationships are really what enable communities to exercise their power. And the COVID pandemic exposed inequities, but it also revealed community strength and leadership, communities really stepping in and stepping up. Success came when First Nations led implementation and external partners kind of took a little bit of a backseat and they supported and not directed. Some great quotes that I heard here was, building capacity at the community level is essential. Technology alone isn't enough. Sustainable funding, training, education, and community practice can make data collection locally driven and meaningful. For the first time ever, First Nation governments and municipalities have data sharing agreements that don't include the territorial government right now, but do include the Public Health Agency of Canada. The second theme was growth and self-determination. So First Nation-led pandemic responses were grounded in love and protection for our elders, and it often surpassed provincial standards. Data ownership enabled confidence and sovereignty in local decision-making. And federal and provincial partners began to realize actively throughout their journey that First Nations are better placed than them to make these decisions. The third finding was First Nation data sovereignty as a theme. Indigenous communities, essentially, we must control our data, and systems often obstruct this. Participants were frustrated by being expected to give data without receiving it, and real data sovereignty means data serving Indigenous priorities. Data sovereignty supports self-determination and control over community health data, and access to it in a timely way supports culturally aligned decisions. An interesting quote is, because of the constraints of the Health Protections Acts, we were limited in what we could do because we didn't have the legislation in place for First Nations to hold public health data. If tests are done in community and data is collected and stored there, that is data sovereignty. Theme 4 was decentralization and democratization of testing. And decentralization is about bringing testing closer to home, closer to communities, and away from colonial centers, really putting the power where it belongs, which is in communities. It supports self-governance, timely access to services, and culturally relevant care. And it really strengthens autonomy in the public health space. So the key wisdoms from this research that I want to share is that overall, community-based diagnostics transform not only care delivery, but also how communities govern data and use it to make decisions that are best for them. Diagnostics became a bridge to self-determination, with potentials to extend this thinking and this practice into environmental and policy domains. So I just want to link back to a key. Health data and land sovereignty are inseparable, and environmental health issues like wastewater, or environmental health issues and opportunities like wastewater or mining threats or algae blooms, they were raised alongside the clinical concerns generally in public health, and decentralized diagnostics can support nation-based environmental governance and ecosystem protection. I might be, can you still hear me because the power is flickering?
Yes, we can.
Good, right on. So the 7 recommendations directly reflect the lived realities and expertise shared by participants. The calls to action is that first, we must center Indigenous leadership in all health data governance. This means not just collecting data, but ensuring Indigenous nations control it from start to finish, which includes the tools needed to actually collect data. Indigenous nations control it. Interoperability needs serious attention. Current informatics systems create barriers to timely access for Indigenous communities. Investment in local decentralized diagnostics, including tools like the gene experts, like the mini lab in the box, but also like environmental monitoring tools, is essential to reduce delays and increase health autonomy. And importantly, Indigenous knowledge must be fully integrated into monitoring frameworks, not just sidelined by colonial data standards or policy reforms. such as the Public Health Act. And these reforms and acts are long overdue to legitimize Indigenous-led systems, health systems. More research is needed to how to explore climate change, contamination, and diagnostics, and how that intersects with Indigenous territories. And finally, true partnerships means co-creating agreements and systems, not just having tokenistic involvement. And these changes are critical to support long-term Indigenous-led health and environmental governance. So just a few limitations here. Sample size was small. And yeah, I wish I got the opportunity to include perspectives from Métis, Inuit, and other nations. And I just want to quickly acknowledge the funders for this research, which were My Nation, Mississauga Nation, UNBC, NEIHR, and FNHA. Yeah, Chimigwech.
Fantastic. Thank you so much, Jennifer. I didn't mean to rush you there in the end. Beautiful presentation, excellent use of visuals, and just amazing work. So congratulations on that.
Thank you.
I would like to open it up to the audience for some questions. You could pop them in the chat or unmute yourself. And while people are collecting their thoughts, maybe I can ask, as an educator and someone that's involved in teaching, I'm curious, you know, what has been supportive for yourself as an Indigenous scholar working within, you know, a very westernized colonial academic environment? What are some things that, say myself, as an educator, could do to help support yourself or students like yourself in your journey?
I think for me, just in my journey, I think I have already been in my power. So I didn't see these systems necessarily as a threat, just something to sort of work alongside. And also my committee were just powerhouses like Dr. Danielle Bain-Smith, you're probably familiar. She's Deputy Minister of Public Health and Indigenous Health. And also Courtney DeFriend, who is the Executive Director within Data and Research within FNHA. So I think it was just like women who are mentors and teachers to help me step into my power so that it doesn't really, some of those Western colonial challenges don't hit as hard because I've been supported to be in my power. Because it's not something that you can change overnight. It's something you have to be immune to and protect yourself from. So as an educator, I would just say like facilitating those connections to having those mentorships with other Indigenous scholars.
Beautiful. Thank you so much for that. And absolutely, you speak to mentorship and the importance of that, and having, you know, allies and folks that will go to bat for you when needed, and being experts in their field and speaking to that. So that definitely resonates. I'm just trying to see if we've got any other questions from the group. Not seeing any, but I do want to end on the note that, you know, what really stuck out to me was, and I think someone had mentioned this in the chat as well, was your comment about innovation not necessarily needing to be something new. We often look to innovation as a shiny, brand new thing, and your comment about how returning to relationships or ways of working that, you know, existed prior to us trying to innovate or recreate, reinvent, was very powerful, and I'll definitely be taking that away with me today as I leave this presentation. Looking at the time now, so 3:05, I would just like to take a moment to thank all of our presenters today. You know, Patty Wilson and her presentation on barriers and facilitators to the uptake of prescribed safe supply at Carrier Sekani Family Services. Then we had Alex and Eva present their presentation and on Kaa-Wiichihitoyaahk. We take care of each other, and the fantastic resources and work that's gone into strengthening and promoting Métis community, including recruitment and retention initiatives. And then ending with Jennifer Cochran and presenting on her work, opportunities to enhance Indigenous data sovereignty. And, you know, that's a conversation that is continually evolving and ongoing, and shared some beautiful lessons and calls to action from her work. And so I'd like to thank all of the presenters as well as all of the attendees for joining today and spending your afternoon with us. Thank you once again, and hope you all enjoy the rest of your day.
Good, thank you.